So let's look at section 12, which is diseases of the rectum and colon. So this section covers diseases that affect the last parts of the gastrointestinal tract, that is the colon and then the rectum. We look at appendicitis, ulcerative colitis, enema colitis, are the two main diseases discussed in this session. And they are discussed in relation to definition, clinical manifestations, pathophysiology, medical management, and nursing management. So at the end, it's expected that you should be able to describe pathophysiology of the conditions, and then identify and address predisposing factors associated with the enema colitis, and then recognize treatment and then management of patients suffering from enema colitis. So we look at enema colitis and then the appendicitis. And enema colitis is the inflammation of the colon as a result of the introduction of chemicals or substances by means of enema. And the examples of such substances include locally prepared solutions, herbs, and other substances used for medicinal purposes to treat various conditions of the gastrointestinal system, such as constipation, abdominal pain, cramps, and then similar problems of the GIT. And I remember that enema colitis, in most cases, children who are admitted, usually it happens to children. Most of them, the parents may be complaining that the child was not passing stools. So what happened was that they give enema, and then as a result, they have inflammation of the colon. So it has been noted in research that soup enemas cause severe colitis with strictures and other complications which sometimes require surgery. And that is exactly what we see in our hospitals. In most cases, we need to do surgery and then find out what is really happening. So it has also been reported that even water enema causes severe colitis, as well as other problems to the patients which may need surgery. And some substances used in enema may include, we have common substances like ginger, onion, pepper, mixture of substances, and then other local substances, and then some preparations. And when patients and their relatives are in the hospital, and during our interaction with them, during subjective history, what they say is that probably they've given ginger solution or onion or pepper solution. And so you can imagine what happens. The most important thing is that in some cases, what happens is that after even giving ginger solution, onion or pepper, to stimulate the child or the adult to pass the stool, what happens is that they are not able to pass the stool. And so in the first instance, they are not able to achieve their aim. And so these things are harbored in the intestinal or the stomach, and then they can cause a lot of inflammatory processes. And when this happens, they can swell the intestines and then other structures. So in children and adults, administration of substances in the form of enema with these various ingredients actually lead to serious problems, especially when the substance is retained following the administration. And this may include abdominal distension. And this is exactly what you see in your hospitals. Those of you who work in the ward, you can see that children who come as a result of distension of abdomen, most of them might have obtained what do you call it, enema. And then a severe abdominal pain with cramps is also likely to occur. And then in children, vomiting is also likely to occur. And then because they are not passing stools, and so intra-abdominal pressure is created, and so vomiting is likely. And content in the GIT or the stomach, because of the built-up pressure, is regurgitated or moves back into the esophagus, and then they vomit. So we have severe abdominal pain, bleeding per rectum, and then severe pain in the anal area is likely to occur. And then digital examination may show liquid stools with blood, and then biopsy specimens may reveal severe inflammation. And so it has also been noted that even prior to surgery, substances such as soap used to evacuate the bowel may cause inflammation of the bowel with pain at the rectum. And in similar situations, patients who had received soup enema, for instance, soup also develop dilated colon, and then in small intestines also develop small fluid levels. So in addition, we have sigmoidoscopy in such patients, and then will reveal ulcerations and obstructions of the middle part of the sigmoid colon, and then acute colitis as a result of detergent enema is rare according to the literature. And then enema colitis also usually develop in few hours time after the introduction of the substance. For instance, if it is soap which has been introduced, it may contain alkali, potash, phenol, as well as sodium and then potassium salts or fatty acids, and then that may also cause liquefaction, necrosis, as well as saponification of the colon wall. And the severity of any enema colitis depends on the concentration and the type of agent that is used. So you can imagine what will happen if somebody is given a salt solution or ginger solution or onion solution or pepper solution, and the contact time with the mucosa is also very, very important. So if it is retained and the person is not able to pass the stool, then havoc is created. So it also depends on the absence of any underlying condition of the colon. So the most common acute chemical damage that may occur include bloody diarrhea, abdominal pain, and then distension of the abdomen. And these are the classic manifestations, as well as severe vomiting, especially if the patient is not passing stools. And so diagnostic investigations usually can do endoscopic examination, and then x-ray of the abdomen, chest, and then stool examination is also done, and then biopsy, WBC, total and differential, and then HB, especially if the child becomes anemic. We have chest x-ray, which may be very important, and then in most cases when the abdomen, the intestines are perforated, we can also check this because of the fluid level under the diaphragm especially, and that is one way of checking. And so medical treatment, patients are put on broad spectrum antibiotics such as ciprofloxacin, metronidazole, and then ivory fluids are also given to patients. And then patients with classic manifestation with this distended abdomen, NL per os, and then insert NG tube for continuous drainage. In severe condition with intestinal perforation, the patient may also need surgery. And so laparotomy may be done as a result of the narrowed mid-sigmoid colon, in which the case the colostomy as well as resection may be performed for this particular patient. It's a big problem, as you can all see in Ghana. Most children's ward in our hospitals in Ghana, we have enema colitis. But this condition, let me tell you, you may not be able to get reading materials for it, because elsewhere we don't have this condition. It's in Ghana and the other West African countries, and then specific countries in Africa where we have this kind of condition because of our behavior and the lifestyle in general. Mothers, when the children are not able to pass through, then they give enema, and then the elderly. So you may not be able to get reference materials. I remember the first time I asked my students to define enema colitis, they couldn't get any definition. So what happened was that one of them, interestingly, got up and said that, say, I was able to look at enema, I was able to look at colitis. So I brought the two together, and then it became enema colitis. And I said, you are right, because there was no material. So take this, and then you can build on it. It's interesting, and it kills most of the children who have this kind of condition. Let us look at appendicitis. Appendicitis, you know appendix, so where it is situated. So appendicitis, we are looking at the inflammation of the appendix, which is about half-inch long tube of the tissue that extends from the large intestine. So actually we don't have any scientific function of this. What we do know is that we can live without it, so without apparent consequences. So the inflammation occurs as a result of infection, which may lead to swelling of the appendix. So appendicitis is considered as medical emergency that may require prompt surgery to remove the appendix. And if it is left untreated, an inflamed appendix will eventually burst and perforate, and then we can have spilling infection materials into the abdominal cavity, and this can lead to peritonitis, a serious inflammation of the abdominal cavity lining, and so we can have peritoneum affected, and that can be fatal unless it is treated quickly with strong antibiotics. Causes: we have appendicitis occurs when the appendix becomes blocked, often by stool, foreign body, cancer. We can also have the blockage may also occur from infection, since the appendix swells in response to any infection in the body. And this the inside of the appendix is called the appendiceal lumen. So mucus created by appendix travels through the appendiceal lumen and empties into the large intestines. And so as you can see on the screen, let me show you the picture. We have the terminal area here. We have the appendix also located over here, and we have the cecum, and we are talking about this area. So we have inflammation of the appendix, and so we have the transverse colon, we have the descending, and then we have the rectum over here. And so here we are talking about the appendicitis, which is inflamed. So obstruction of the appendiceal lumen causes appendicitis, and so obstruction may be either partial or complete. Complete obstruction may be a cause for emergency surgery, and the mucus backup in the appendiceal lumen, causing bacteria that normally live inside the appendix to multiply. As a result, the appendix swells and they become infected. Other sources of obstruction include parasites. We have growths that also obstruct the appendiceal lumen. Enlarged lymph tissues in the wall of the appendix caused by infection in the gastrointestinal tract or elsewhere in the body. Inflammatory bowel disease, trauma to the abdomen, and then worms in general. And so an inflamed appendix will likely burst if not removed. So bursting spreads the infection throughout the abdomen, and the potential dangerous condition called peritonitis. So as already noted, appendicitis lead to more emergency abdominal surgeries than any other cause. Clinical manifestations: diagnosing appendicitis can be tricky and then complicated and delicate, and the symptoms of appendicitis are frequent, vague, or extremely similar to other ailments, including bladder or urinary tract infections, gastritis, intestinal infection, and then ovary problems. There are other factors that we can also look at. Other symptoms like loss of appetite. We have nausea, vomiting, constipation, and then other possible. And so diagnosis of the condition. A doctor or other healthcare provider can diagnose most cases of appendicitis by the person's medical history, also doing physical assessment, and that can also help. And the doctor may also do laboratory investigations. We also, based on the medical history and the physical examination, as we have already done, and then we can do guarding, which occurs when the person subconsciously tenses the abdomen during the examinations of the abdomen. And then we also have rebound tenderness, where the doctor tests for rebound tenderness by applying hand pressure to the patient abdomen and then letting go. Patient feels pains, and then upon release of the pressure indicates rebound tenderness, and that indicates that probably there's a peritonitis as a result of leakage of the intestinal contents into the peritoneum because of the perforation. There are other signs like Robson's sign, where the doctor tests for Robson's sign by applying hand pressure to the lower left side of the abdomen, and pain felt on the lower right side of the abdomen upon the release of the pressure on the left side indicates the presence of the Robson's sign. And I hope in your physical assessment, Nurs 231, you have done Robson's sign when you were looking at the abdominal palpation. We have the swab sign, which later you can read. We have the Brambeck sign, which we have already looked at. So I want you to read on the following. You have the cautious sign. We have the resistance sign. These are all signs used to diagnose what we call the appendicitis patient. And then we have the Bartholomew Mercian's sign, which we can also have the obturator sign. I've provided the Nurs, but you have done all these things already, so later you can take your time and go through as part of your physical assessment. And then you can also do laboratory investigations. Blood tests are used to check for signs of infection. For instance, you can do laboratory tests, and then you can also do urinary tests, urinalysis, and then the blood, you can do WBC, total and differential, and then the imaging test, computerized tomography. But this may be an advanced test that you may do, whereby you want to take multiple sites, cross-sectional images of the body. But simple chest X-ray can tell you whether there is a perforation, and then whether there is a leakage of fluid into the abdominal cavity in general, and that will show under the diaphragm that there is a fluid level under the diaphragm. That indicates that the perforation has occurred, and you don't need to waste time at all. Here we need to prepare the patient for surgery, and then ultrasound is sometimes used to look for signs of appendicitis, especially in people who are very thin or very young individuals. We have already mentioned X-ray, and then the treatment is very important too. Treatment of acute appendicitis with antibiotics may eliminate the need for surgery. So in the initial phase or the acute phase, the principle is that we need to start with antibiotics. And the general principle of management of this level refer to the notes on typhoid or general management and observation in the case of acute stage of the condition. So before possible surgery, in addition to other treatments. So look at that, and then in advanced stages, you can do surgery, and the surgery will take care of that. We have laparoscopy surgery, and then other types that can also be done. And then non-surgical treatment may be used if surgery is not available, if person is not well enough to undergo surgery, or if the diagnosis is unclear. Some researches suggest that appendicitis can get better without surgery. So we need to monitor the patient closely. So non-surgical managements with medication and then NG tube, and then we can manage the patient. So non-surgical treatment include antibiotics to treat infection, and then a liquid or soft diet until infection subsides. A soft diet is also low in fiber and then easily breaks down in gastrointestinal tract. Is very, very important at the initial stage. And then pain management, pain from appendicitis can be severe. So we need to give strong antibiotics, like narcotic pain medication recommended for pain treatment or management prior to possible surgery. And then in the past, it was somehow agreeable that we don't need to give pain medication, because if we are waiting for a doctor to come and assess the patient and you have given pain medication already, it will interfere with the doctor's assessment. But here's our case. In Ghana, for instance, if the patient has come in with a suspected appendicitis, and probably the doctor is not present in the ward, and the patient may be wailing, the patient may be weeping and with severe pain, do you think you have to wait for the doctor? You can't, you don't have to. So there should be policy and then hospital protocol when the doctor isn't available, what the nurse can do. For instance, you know, there are so many things that go on in our part of the world. Even the doctor may be doing something else. The doctor on duty may not be available, and the patient going through severe pain. You can't wait. So there should be policy and protocol for each of the hospitals. Before the doctor comes, there's something that we need to do, especially the management of the pain. The pain alone can kill the patient. So if one school of thought says that we can't reduce the pain, we should wait for the doctor. Another thing is that our part of the world, we can't do that. Probably those who suggested that nobody should give the pain management, probably in the Western world, where the doctors are just close, they are around, and then you should just wait for them to come and assess the patient within the next twinkle of an eye. But here in Ghana, it may be a problem. So we need to look at it and then consider what we need to do. But there are two schools of thought. Either you wait for the doctor to come and assess, or you have to do something. And then looking at the situation, you can't leave the patient just like that. So these are the things that we need to take into consideration as part of the management of prognosis with adequate care Most people recover from appendicitis and do not need to make changes to their diet, exercise, or lifestyle. And then full recovery from surgery takes about 4 to 6 weeks. And then limiting physical activity during this time allows tissue to heal well. Prevention of appendicitis. There's no way to prevent appendicitis. However, appendicitis is less common in people who eat foods high in fiber, such as fresh fruits and vegetables. I want you to look at ulcerative colitis, which is not very common in our part of the world. You can still read around that. I have the references over here. Thank you very much.